The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version. Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. This is part 3 of my review of nuclear medicine bone scans for radiology and nuclear medicine board exams. Upon releasing this episode, I will make the free downloadable study guide covering content in parts 1, 2, and 3 of nuclear medicine bone scans available for a free download on my website, theradiologyreview.com. A quick reminder to follow at RadRevPodcast on Twitter or Instagram. And I also want to remind you of the discount code section of my website, where you can frequently find discount codes for things like online subscriptions for QBanks and other educational resources. Without further ado, let's get into the questions and answers for this episode. First question. What are classic imaging findings that can be seen on a bone scan for patients who are on bisphosphonate therapy? The first thing I would remember is a proximal femur fracture, sometimes termed a bisphosphonate fracture, or even more specifically, a bisphosphonate-related proximal femoral fracture. On a bone scan, this would typically manifest as an area of focal uptake in the proximal femur that involves often exclusively the lateral femoral cortex of the proximal femoral diaphysis, which is located distal to the lesser trochanter. That is a mouthful, so let me go through that one more time. You would expect uptake often exclusively along the lateral femoral cortex of the proximal femoral diaphysis located distal to the lesser trochanter. This can be a unilateral or bilateral process. Note that this is an insufficiency type fracture and is associated with delayed fracture healing and has a risk for progression to complete fracture. When this is seen, correlation with radiographs of both femurs is often helpful and would be predicted to show a predominantly simple horizontal fracture, which is classically non-comminuted. No associated mass on imaging or history of major trauma is expected in a bisphosphonate-related proximal femur fracture. Classic clinical history would be that of an older woman with osteoporosis. Treatment of a bisphosphonate-related proximal femoral fracture often involves withholding further bisphosphonate therapy and surgical management to prevent completion of the fracture and promote healing. Second, I would also remember bisphosphonate-related osteonecrosis of the jaw. This is development of exposed bone with osteonecrosis in the maxillofacial region in patients on typically longer-term bisphosphonate therapy. Note that biopsy of the bone for diagnosis can actually worsen the process, and diagnosis is often therefore clinical and based on imaging. On a bone scan, expect abnormal, focal, often intense uptake in the jaw region. Note that bone scan is more sensitive compared to radiography in the early diagnosis of bisphosphonate-related osteonecrosis of the jaw. Those are two classic bisphosphonate-related findings on a bone scan that you definitely should be aware of for board examinations. Next question. What are key differences of physiologic uptake on a bone scan of a child or teenager compared to a physically mature adult? Children and young adults show intense activity in the physes secondary to bone growth with associated osteoblastic bone building activity that is not seen in a physically mature adult. Normal physiologic uptake can also be more pronounced in children and young adults in the sternum, sacroiliac joints, articular surfaces in general, and the nasopharynx. Now I'm going to spend some time talking about three-phase bone scans as I had previously promised. So let's go ahead with our first question. What are the three phases of a three-phase bone scan? Now, this may sound like a pretty easy question, but this is absolutely important that you understand what the three phases are and what is being imaged at each phase. The first phase of a three-phase bone scan is blood flow. Second is evaluation of blood pool, which is tracer going into the soft tissues. And third is delayed bone imaging, where you evaluate for bone uptake specifically. In the first phase, the blood flow phase, imaging begins immediately following injection of the radiotracer and is performed to evaluate for increased blood flow. This is a dynamic phase that usually requires positioning the patient in front of the camera first and then immediately starting imaging at time of injection, taking images every few seconds over about 60 seconds. The second phase is blood pool, in which imaging is performed after the blood flow phase, and in which imaging is performed over several minutes to evaluate for abnormal radiotracer accumulation in the soft tissues. Finally, about 2 to 4 hours after injection, delayed phase images are obtained to evaluate for abnormal radiotracer accumulation in the bone itself. I would think about the first two phases as telling you what is going on in the soft tissues around the bone in terms of infection or inflammation, and the delayed phase telling you if bone pathology is present. Often, a three-phase bone scan is performed to evaluate a clinical or imaging finding of concern, and imaging is focused over a certain region of the body only. However, it may not be unusual in cancer patients particularly to obtain the initial imaging in all three phases over a specific area of concern, and then to also get whole body delayed imaging in addition to evaluate the entire skeleton for metastases or other abnormalities. Finally, SPECT CT fused images may be obtained at the areas of concern as clinically directed. Next question. What are general findings of infection on a three-phase bone scan? First, look for asymmetry in uptake. Infection or inflammation will show asymmetric uptake due to increased asymmetric blood flow and blood pool due to inflammation in the affected tissues. Infection in the bone will also show abnormal delayed radiotracer uptake on the delayed phase of imaging. Next, how can one differentiate cellulitis from osteomyelitis on a three-phase bone scan? Cellulitis demonstrates increased uptake on a three-phase bone scan on the flow and blood pool phase, but shows no abnormal uptake on the delayed phase. To explain further, cellulitis is a soft tissue infection associated with increased blood flow and inflammation in the soft tissues, but no bone involvement. Therefore, increased uptake is expected on blood flow and blood pool imaging, but importantly, not on delayed imaging with cellulitis. On the other hand, osteomyelitis is infection of the bone and has inflammation of the surrounding soft tissues, and therefore is expected in classic cases to show uptake on all three phases. Remember that osteomyelitis can be detected on bone scan days to weeks before changes will be seen on a radiograph, and the sensitivity of a bone scan for osteomyelitis is something like 95%. Note also that blood flow and blood pool phases should resolve within months of treatment of osteomyelitis, but abnormal bone uptake may persist for something like 2 years. Finally, remember that osteomyelitis is three-phase hot on a bone scan. Cellulitis is only hot on the first two phases, which are the blood flow and blood pool phases. Next question. What are classic imaging findings of complex regional pain syndrome, also termed reflex sympathetic dystrophy, on a 3-phase bone scan. With complex regional pain syndrome, increased blood flow and blood pool activity and delayed activity in a juxta-articular distribution, most classic on a hand, is expected on a bone scan. This is essentially an ant mini finding, so make sure and look up the imaging appearance of complex regional pain syndrome on a bone scan if you don't know what this looks like. Remember that clinical symptoms of complex regional pain syndrome include pain, swelling, and vasomotor instability, and this is often post-traumatic in etiology. Next, how can one differentiate orthopedic hardware infection versus loosening on a bone scan? Infection of hardware would typically show a more generalized increase in activity around the prosthesis, whereas loosening without infection would show a more localized focal area of uptake, particularly on blood flow and blood pool imaging. This rule is not perfect, but in general, expect more intense and diffuse abnormality around the prosthesis with infection and a more localized focal area of uptake, often around the more distal stem of a prosthesis with loosening only. Next, name several abnormalities that are 3-phase positive on a bone scan. This is not an all-inclusive list, but entities that are 3-phase positive on a bone scan include an acute fracture, osteomyelitis, complex regional pain syndrome, inflammatory arthritides, orthopedic hardware infection or loosening, aggressive and vascularized tumors, the immature phase of myositis ossificans, and finally osteoid osteoma. Next, what are 2 classic entities to keep in mind on board exams for something that is only 2-phase, meaning blood flow and blood pool, positive on a bone scan? Entities that are only positive on the first 2 phases of a bone scan, the blood flow and blood pool phase, are really 2 primary ones, at least in terms of what I would remember for board exams. First, consider cellulitis of the soft tissues. Second, consider a soft tissue malignancy without bone involvement. Next question. What are classic entities to keep in mind for board exams for things that are only hot on the delayed phase of a 3-phase bone scan? When blood flow and blood pool are normal, but delayed images are positive on a 3-phase bone scan, consider osteoblastic metastases, metabolic bone diseases, and I have reviewed both of those on the prior 2 episodes. Also consider non-acute fractures, and it is non-acute because that initial inflammation that would cause the increased blood flow and blood pool has now resolved. So non-acute fractures can be hot only on the delayed phase of a 3-phase bone scan, whereas acute fractures are expected to be hot on all 3 phases. And finally, for delayed phase uptake only, also remember medial tibial stress syndrome, which is a fancy term for shin splints. And that leads us to the next question. What are classic findings on a bone scan for medial tibial stress syndrome, which is the fancy term for shin splints? Classic findings on a bone scan for shin splints include longitudinal uptake along the posterior and medial aspect of the tibia that is often best depicted on lateral views, with classically normal uptake on blood flow and blood pool images. Remember that if you also see early phase uptake, meaning uptake on blood flow and blood pool images, this suggests possible stress fracture that may be acute, which is a known complication of medial tibial stress syndrome if stress from running is excessive. And I would say this is another Aunt Minnie finding, so if you do not know what shin splints or medial tibial stress syndrome looks like on a bone scan, please look up images so you are ready to recognize this on your testing days. And that brings us to the last and final question for this episode and the concluding question for my 3-part review of nuclear medicine bone scans, at least for now. The question is, if radiotracer fails to adequately clear from the soft tissues on the delayed phase of a bone scan, what classic entity should you consider first? And perhaps a secondary question is, what should you do about this? I would say for board exams, the most classic thing you should consider is renal failure. Poor renal function limits the clearance of radiotracer from the soft tissues of the body. If this happens, obtained delayed imaging up to 24 hours after injection to allow more time for radiotracer to clear from the soft tissues, which will improve the signal to noise on your image. The noise of soft tissue uptake on the delayed phase will be less, and that will increase the signal from the bone itself. Given lower counts that will be present in the body due to radiotracer decay at 24 hours, a longer imaging acquisition time can be helpful when extended delays in imaging are necessary. Some refer to a delayed 24-hour imaging time point as the 4th phase of a bone scan. Another scenario where a delayed 24-hour imaging time point, or the so-called 4th phase, may be helpful is in a neuropathic foot, where peripheral blood flow may be reduced and one needs to evaluate for cellulitis versus osteomyelitis, for which radiotracer clearance from the soft tissues is helpful to improve signal-to-noise of the bone itself. I hope these 3 episodes reviewing nuclear medicine bone scans for board exams has been helpful for you. Do not forget to download the free study guide at theradiologyreview.com. Keep up the good work, keep learning, keep studying hard, because you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.